Welcome to USMLE World, where we ask, answer, and explain USMLE questions. Today, we're diving into Step 2, Internal Medicine, focusing on endocrine, diabetes, and metabolism. Question number 4. For the following case. If her current condition is due to an anti-diabetic drug, which of the following is the most likely culprit agent? A. Acarbose. B. Canagliflozin. C. Glyburide. D. Long-acting insulin. E. Metformin. F. Pioglitazone. G. Short-acting insulin. The case scenario is: a 64-year-old woman is brought to the emergency department due to confusion and lethargy. The patient was asymptomatic when her husband left for work in the morning, but when he arrived home, he found her in bed weak and disoriented. The patient's medical conditions include type 2 diabetes mellitus and hypertension, for which she takes multiple medications. She does not use tobacco, alcohol, or illicit drugs. Temperature is 37 degrees Celsius, blood pressure is 140 by 70 mm mercury, pulse is 74 beats per minute, and respirations are 18 breaths per minute. On physical examination, the patient is somnolent but withdraws all extremities to pain. Laboratory testing shows an elevated serum C-peptide level. The question is: if her current condition is due to an anti-diabetic drug, which of the following is the most likely culprit agent? Your options are: A. Acarbose. B. Canagliflozin. C. Glyburide. D. Long-acting insulin. E. Metformin. F. Pioglitazone. G. Short-acting insulin. You have 15 seconds to type your answer in the comment box. Congratulations if your answer is C, which is Glyburide. This question is designed with the focus to assess your ability to apply pharmacotherapy. This patient with type 2 diabetes mellitus has acute confusion and lethargy, which is consistent with symptomatic hypoglycemia, a common adverse effect of anti-diabetic medications. Her elevated C-peptide level is further indicative of a medication that stimulates pancreatic insulin secretion independent of blood glucose levels, such as sulfonylureas, for example glyburide, or meglitinides. Insulin is synthesized in pancreatic beta cells as preproinsulin, which is guided by a signal peptide into the rough endoplasmic reticulum during translation. The signal peptide is then removed, converting preproinsulin to proinsulin. Protein folding and disulfide bond formation take place as proinsulin traverses the rough endoplasmic reticulum. Proinsulin is then transported to the Golgi apparatus, where it is packaged with proteolytic enzymes into insulin secretory granules and cleaved into mature insulin and C-peptide. C-peptide and insulin are then co-secreted from pancreatic beta cells in equimolar amounts. When hypoglycemia is due to excessive endogenous insulin production, for example sulfonylureas, meglitinides, insulinoma, C-peptide levels are elevated. In contrast, exogenous insulin and insulin analogs, for instance, insulin-like polypeptides with alterations in the amino acid sequence to optimize pharmacokinetic properties, do not contain C-peptide. When hypoglycemia is induced by these agents, endogenous insulin secretion is suppressed and C-peptide levels are low. Look choice D and G. If you choose any option other than C, you are wrong. Let's briefly discuss the other options. A. Acarbose. Acarbose inhibits alpha-glucosidase in the intestinal brush border, impairing the hydrolysis of polymeric carbohydrates and leading to decreased postprandial glucose absorption. Acarbose indirectly decreases endogenous insulin and C-peptide secretion by reducing postprandial hyperglycemia. B, E, and F. Canagliflozin, metformin, pioglitazone. Sodium glucose cotransporter 2 inhibitors, for example canagliflozin, dapagliflozin, act in the kidney to decrease the reabsorption of filtered glucose. Major side effects include hypotension and urinary tract infection. Metformin is a biguanide that decreases hepatic glucose production, decreases intestinal glucose absorption, and increases peripheral glucose uptake and utilization. Thiazolidinediones. For example pioglitazone, increase insulin sensitivity by increasing glucose utilization and decreasing glucose production in adipose tissue, muscle, and liver. These agents have a low risk of hypoglycemia and do not increase endogenous insulin secretion. Your take-home message from this question is that proinsulin is cleaved into mature insulin and C-peptide, which are co-secreted from pancreatic beta cells in equimolar amounts. Circulating levels of C-peptide can be used as a marker of endogenous insulin secretion. Sulfonylureas and meglitinides lower blood glucose by stimulating pancreatic insulin secretion. Hypoglycemia due to these agents is associated with elevated C-peptide levels. Did you get the answer? Proceed to the next question by clicking above only if you've got the answer right. However, should you fail to answer correctly, it is imperative that you watch this episode again. Remember, understanding is key to progress. Unlock the secret to acing your medical exams, especially the USMLE, with our top-notch resources. Ensure you and your friends are well prepared by hitting that like button, sharing this wealth of knowledge, and subscribing to our channel. Remember, your success is just a click away.